So I'm excited to introduce our keynote speaker tonight. I'm going to read her bio because she's pretty amazing. Katherine Kim is an assistant professor at University of California, Davis, the Betty Irene School of Nursing. Betty Irene Moore School of Nursing. Dr. Kim's research focuses on the use of information technology such as mobile, social, and distributed health systems to improve care coordination, community health, and stakeholder-engaged research. It's fancy. Her current research spans cancer, obesity, and heart disease with a particular focus on health equity. Dr. Kim's over 20 years of previous experience as a hospital and clinical manager, an entrepreneur, CEO of a venture-funded startup, leader of a technology incubator, and founder of a consulting firm. You have an interesting backstory. And in software product development with Oracle. She received a PhD at UC Davis, an MPH MBA at UC Berkeley, and a BA at Harvard, so no big deal. Please give it up for Dr. Kim.
Thanks. Hello. I mean, it's kind of like that because I was in business school and did my first startup business plan as a class project, and then got scooped by the very first online wedding registry. We wrote the business plan before they did. We got scooped, but I did eventually became an entrepreneur. So I'm excited to talk with you about engaging patients with mobile and social technology. So I'm going to tell you a little bit about sort of my perspective on what it means to engage patients. I'm going to give you just some very brief examples of work that we've done in research using these technologies. And then I'm going to try and give you a pitch about why you entrepreneurs should work with researchers and how that can help you. First, how many people have heard of the Precision Medicine Initiative? About half the room. So Precision Medicine Initiative was launched by President Obama last year. And the goal of precision medicine, the goal of precision medicine is to enable a new era of medicine through research, technology, and policies that empower patients, researchers, and providers together to develop individualized care. So the three pitches you heard today were all forms of individualized care, ways that we can use technology, work directly with the people that we're trying to serve, and bring that information back into the process of providing care that actually works individually for that person. So that's the Precision Medicine Initiative. The reason this is important is that this has now become part of the national conversation about healthcare. This focus on patients working together with the healthcare system. So they're no longer just recipients of care, they're actually partners in care. So this comes from a good friend of mine, Hugo Campos, who was named by the White House last year as Precision Medicine Champion for Change. He's a patient with an implanted defibrillator who got into this area of trying to get access for patients to information from their own medical devices because he got laid off. And he can't survive without this defibrillator, but when he got laid off and his COBRA ran out, he couldn't afford health insurance anymore, which meant that he couldn't get his device interrogated, so he didn't know what was going on with his heart. And he's got a congenital heart condition, which means that when he starts going into afibrillation, he's at a very high risk for death. So this is a really critical kind of information that he needs to know about, on a daily basis to say, do I need to go to the emergency room? Do I need to go to my doctor's office? What can I do right now to make sure that I'm not going to die? Well, he wasn't allowed to get that because the data on these devices are the intellectual property of the device manufacturers. Legally, patients are not allowed to get it, except by after the fact requesting their medical records from their doctors if a report was sent from the device that something was wrong to the doctor from the company. Right, which means 3 or 4 weeks later he could get a copy of it, and that doesn't never work. So this was a slide that he let me use. And he says, patient engagement is a means to an end. It's not an end in itself. The goal is autonomy, patient autonomy. So I want to talk about a couple little terms. So when you think about patient engagement, there's sort of an external view and an internal view. So the outside-in perspective, and I'm going to compare sort of how we talk about it in the informatics or technology world and how we talk about it in healthcare. So the outside perspective, when we think about developing technologies or software or things that we want patients to engage with, we think of user-centered. So I, as a designer, think about you and what you might do with it, right? So it's an external perspective. Or user engaged, meaning I'm going to talk to you, I'm going to observe you, I'm going to try to understand what it's like for you. But it's a very external perspective. In healthcare, we have very similar terms. It's patient-centered or patient engagement. So patient-centered is from the perspective of the health system, from the clinicians, from the administrators. What can we do to arrange our services, arrange our care, to focus on you? How do we get you to work with us? Or how do we make sure that we have interaction with you? But it's very external. If you're from the inside perspective, meaning you are the user, you are the patient, you think about how can I drive what I need, right? How can I design what I need so that it works for me? Those are the terms in informatics. In healthcare, it's empowerment, patient empowerment, which means we give power, we give control to the patient rather than doing something to them. Or another term is shared decision making. Right? We no longer have the clinician make decisions for the patient, but we have the patient part of the process of making the decision. So I think that internal, external perspective is really critical when we start to try and design solutions and try to develop interventions that use technology to engage patients. All right, so this is the challenge that we've been working on for the last couple of years. It's care coordination. So we're not dealing with the treatment itself. We're dealing with the coordination of the treatments. Okay, so care coordination happens, and this is an example from cancer. We've been doing a lot of work in cancer. So you have a patient, right? You have maybe some other family members and caregivers that work with them. And that patient, when they have cancer, go to hospitals. Sometimes they're admitted to the hospital. They have a set of specialists that they see while they're in the hospital. They also have physicians in their primary care practices or specialist practices that they go to. So they're going to clinics and offices. And you have a whole set of other physicians and other providers that treat them while they're in their offices. You have a set of community services, might be meal services, transportation services, assistance with medications, all kinds of community services out there for cancer patients. So you might go there. And then you go to labs and you go to radiation centers and you go to all these different places. Well, the problem is that you have a different information system at every one of those locations. And this is a smattering of the electronic health record systems that any patient might actually encounter during the time that they're in one episode of treatment. And if you know anything about electronic health records, most of them do not ever transfer data to anyone else, right? Except for claims, because they need to get paid. Claims get transferred electronically all the time. But clinical data is very difficult to get integrated. So what happens is that patient and their caregivers and family members become the integration hub, which means they are physically integrating data, like they take copies of records and they have rolling bags, and they actually carry copies of the records from place to place because they don't know if that provider is going to have any of the data that just got created from any of those other providers. Right? So have you seen this? The patients, they literally carry rollables with all their medical records just in case. They also become the electronic integration hub. And so Hugo gave me this, shared a story with me, that anytime he goes to the doctor, anytime he goes to any care provider, labs, whatever it is, anytime his father does, because he's also a caretaker for his father who has the same heart condition, he asks them for electronic copies of whatever he can get. Anything they have electronically, he asks them for it. And then he has his own file system. He created his own file system in a database to keep all of those things. He scans in all the inserts from his medications. So if he gets paper, he scans it in and puts it in his file system. So many patients are trying to be the electronic integration hub as well as the physical information hub. So you can imagine if you're sick, how overwhelming this is. If you're not sick, how overwhelming this is. But now add an illness to that, and it becomes completely unmanageable. And it becomes unmanageable for your family members who are trying to help you with that as well. So that's the challenge that we're trying to address. Here's another way of looking at it. This is a concept that we created called community-wide care coordination at the point of need, not the point of care. So again, this is an example from cancer. And we have family teams, healthcare teams, and community teams in the 3 different levels. It always starts with the person, right? The person who's ill is at the center of everything, and they are always involved in everything. But then you have different teams that get involved depending on sort of what stage of the cancer life cycle they're in. So if you're in prevention, Or if you're getting screening, right, before you've been diagnosed with anything, you're usually just getting care in primary care. Right? Your family is definitely involved. Sometimes they're helping you get to your appointments or scheduling appointments, things like that. You probably have been approached by some sort of health outreach program. If you're at Kaiser, you get a call, you know, you're a woman, you get after 50, you get a call every 2 years that says, come in for your mammogram, right? Or if you have, if you're at Sutter, they mail you these flyers, you know, every couple of years, make sure you get in your prostate screening, right? So there's some sort of health outreach program that's also interactive. But there's not a whole lot else going on when you're just in prevention and screening. Now, patient navigation starts to come in when there's a suspected diagnosis. So that's the bridge into diagnosis and treatment. So once there's a suspected diagnosis, or when there's a confirmed diagnosis, you get a whole bunch of other teams that get involved. Lots of specialists, you know, lots of services. You often have patient communities because the first thing that almost anyone does when they get a condition is they go to Google, or they go to WebMD, or they go to the American Cancer Society, and they look for a patient community. Other people that have the condition they have, so that they can get support and information. So you have all these different teams that start to get involved in diagnosis and treatment. And then you go to survivorship and end of life. Now survivorship we define as any time you've ended an active period of treatment. Okay, so it doesn't mean for the rest of your life. It can be a short period of time after active treatment. So now you get a whole set of other teams. You usually gotten transferred back to primary care. Your family's still involved. You might have you know, checkups every once in a while with your oncologist still. Towards end of life, you now have another set of groups that you're involved in, hospice, respite care, those sorts of things. But you can imagine, over the lifetime of a cancer patient, they've got all these different teams that come in and out of their coordination. So this is another way of looking at that care coordination problem. What do you do over time to manage information and decisions across all of these teams that are interacting with you, right? And to try and organize that in some way that makes sense to you. So that's the part, oh, I should say one more thing. Every one of these overlaps, of these bubbles, is a point of view. There's a handoff of something at every intersection. A handoff of information, a handoff of data, a handoff of the patient, a handoff of a task or activity, right? So the point of need for coordination is at every one of those intersections. Right? So it's not at the point of care, it's not always at points of care. Right? This is not, you're not getting care here, you're not getting care. But it is a point of need for the patient to receive coordination or to get assistance with coordination. Right? So that's what we call point of need. Okay, so that's the challenge. What do we do about that? And so we thought really carefully about if I am looking from the inside perspective, if I am the patient, if I'm the family member, what do I need to be empowered, to be autonomous? So one of the things that we worked on, and this is we just finished the prototype of this, we call it On Point, which is coordination at the point of need, so we call it On Point. This is a mobile application that's focusing on a couple of key things. It's focusing on two specific activities that need to occur. One being, how do I understand what my medications are and the best way to take them? And the second being, how do I know whether symptoms I have are important and require me to do something? Okay, so it's not trying to do everything at once. It's trying to focus on two very specific points at which you need coordination. We actually started this project thinking about people who had many different conditions. So most people who have one chronic condition have more than one chronic condition. Almost nobody just has one, right? And so we actually started thinking about people with heart failure. And on average, people with heart failure actually have six medications they're taking and have at least four comorbidities or 4 other conditions that they're managing. So very complex. It's amazing how frequently you run across people with cancer who also have liver failure and also have diabetes and also have heart disease and also have these other things. But what happens is they get sort of consumed by managing the cancer, and so they can't deal with it. Okay, so we actually started with heart failure and those comorbidities, but we moved this over into cancer as well. So this was the actual application that we prototyped. And this one I'm just showing you is the one decision-making point regarding medications. So one of the issues for people who have lots of different medications is each medication has a different purpose. It has a different time when you're supposed to take it. It has different instructions. Take with food, without food, take 3 times a day, take 2 times a day, take morning, noon, night, and right before you go to bed. Don't do this when you take it, do this when you take it, right? So you have 6 different medications on average just for heart failure, not for the other comorbidities. And you've got to organize. How do I actually take this in a way that I can manage? And what most people do is they just say, I'm not going to take all of them. I'm just going to take the ones I think are important, right? Which is a problem. It's a real problem. Okay. So we said, what could we do about just organizing the medication schedule? And by the way, one of the patients that co-designed this with us has 22 medications he takes every day. So that's a huge cognitive load. Okay, so what can we do just to help people figure out what is the optimal schedule for me to take my medications? So that's what we did. We have an interface that actually allows you to scan the barcode or take a picture of the label, get all the insert information so we can go to an RX norm and grab all that data from the national database. We can actually scan in the insert or get the insert information that has all the signs and indications and everything you're supposed to watch out for. We get all that in there for them, right? And so once all that's in there, then we have the information that says what you have to do before and after the medication, when you're supposed to take it, how you're supposed to take it. And we're working with Purdue to actually develop an algorithm that takes all that information and then suggests an optimal schedule with the least number of different points at which you take medication. Because you don't want to be taking 22 times a day. You'd like to get it into 3 or 4, easy to remember time. So we're working with Purdue. So this is the schedule that gets generated with pictures of the actual medication, because medications, when you look at the label and you're trying to read the label, you can't see quite what the name is, and some of them are kind of familiar. And when you put it all in your hand, you're like, oh, which one was that? Which one was that? Which one's that? So we have the actual pictures, so they're not all red and white, but we would have the actual pictures of the pills by time when you're supposed to take it. And then, because people don't take the pills from their smartphone, they actually take it usually from a pill box or from the actual medication bottles. We deliver this information with how to fill your pill box for all 22 medications. So you can see there was just one point. We're trying to fix something from the patient's perspective that is a problem for them. It's not the whole process, it's one point. Right? So you can figure, then do this, and we'll do the next one, the next one, and the next one. Eventually you'll get to managing the whole process for them, but you've got to sort of start with one paint room. So this prototype is done. This was actually funded by Citrus, which comes out of UC Berkeley. It's a collaborative of UC Berkeley, UC Davis, UC Santa Cruz, and UC Merced. So we got seed funded through Citrus to develop this prototype. We just finished it. Okay, so the second example is the personal health network. Okay, so this is, again, using mobile and social technologies, which I should point out, the reason we use social networking technology is because most healthcare systems assume that there is the right way to do everything, right? We follow a clinical protocol, a clinical guideline that says you're supposed to do this at this time, and then you do that, and then you do that, and then you do that, as if all of healthcare is linear, and we know exactly what to do at every point. We know that that is an absolute lie. We don't know what the best thing is to do, and we don't always follow an exact schedule for every patient. You have to be able to promise. But if you have complex processes, and every individual is different, how can you actually have a system that says you treat everyone the same? Right? You can't do that with most of the information systems in healthcare. So we said, what kinds of technologies do we have out there that allow you to take lots of different people with their own individual needs and preferences and information sharing, and allow them to design the process themselves? What kind of technologies allow you to do that? Social networks. Yeah, social networks do that. They don't pre-design the way that you're supposed to communicate. They don't pre-design what you're supposed to do at what time. They allow you to collaborate in real time. So we said, oh, could we apply that to this kind of problem, which is a care coordination problem? So that's what we did. This is focused on patients with cancer, any site, any stage, but they all were starting chemotherapy. So one of the most complex points in the process in the cancer patient's life cycle is when they're doing chemotherapy. And it's the very beginning for them, so they have a lot of emotional concerns, and there's a lot of coordination that's happening. Okay, so what is this? So we use a social networking platform, and we said, what are the things that patients need during coordination? Well, first, they need to know who's in my healthcare team. And patients said, I don't even know who all these people are. I go to the clinic, and a nurse comes in, and a tech comes in, and somebody else comes in, and maybe it wasn't my oncologist, but I think it was another oncologist who's on that day. They don't even know who is in their healthcare team. They don't know their names, they don't get introduced, they don't know how to contact them, they don't have phone numbers, right? They just have the general number for the clinic. So one, they just want to know who's assigned to them. Like, who are these people, and what are their roles in my care? And then they want to know what's all the stuff that's supposed to be happening. When are the appointments? What are the things I'm supposed to do? When is it supposed to happen? Who's supposed to be doing what? So that's what's called a shared care plan. The third is we send everybody to this chemotherapy education class, which is great, but chemotherapy is not the same for everybody, depending on what chemo you're getting and what kind of cancer you have. It's different. But we have one chemo class. It's an hour, right? It's an hour. Yeah. It's once a week, twice a week, and everybody goes to the same one. And I don't know if we even give binders anymore. We do. We give a binder. So we've got all these brochures and Xeroxes of old Xeroxes of old Xeroxes of things to do when you think you might be having this symptom and you can't read it all. And then we send them off with this. And then when they go home, they are starting to have an issue. They're like, oh, where was that in this binder? And if you're feeling, anxious and you're starting to feel ill, you're not going to go through this binder, right? You don't even know where to find it. And then your family member comes over and says, okay, calm down, I'm going to help you. Where did you put the binder? And you're, I don't know where I put the binder, right? I don't know. Okay, so all that patient education that we so carefully put together and gave to you in an education class now is not accessible to you and not helpful at all. Okay, so what do? We put all that into a library. But if you put all that into a library, and there are hundreds of pieces of information in the library, it becomes the virtual version of the library, which is not helpful. So what do? We use these. These are the assessments. We have proactive assessments that the care coordinators, it's automatically sent to a patient. So for example, symptom assessment we do every 2 weeks. There's a screening assessment that gets sent through the social networking technology to the individual. They do a simple screening questionnaire, and we identify the biggest concerns, and we kind of go deep into, with evidence-based protocols, deep into questioning about that particular symptom. And then based on that, the care coordinator can say, oh, so this is what you need. You're having a lot of anxiety. You don't want to take anti-anxiety medication, but you're willing to try and do breathing exercises or stress reduction exercises. Let me pick from this library and send it to you. Sorry, send it to you here. It goes here and it gets delivered to you. That material specific to what you need at that time gets delivered to you in your dashboard. So when you think from the patient's perspective, what I need to make my own decisions here are these 4 things. Right? Then let's build those 4 things and allow the patients to decide when they need them and how they're going to use them. Okay, so the social networking part is really this. They can put anyone in their social network, right? But it's built around each individual patient. So it's the patient, we automatically put the healthcare team from UC Davis in there, but they can say, I want these family members, I want these friends, I want my primary care doc, I want my transportation service, I want my patient navigator. Those are the people I want here, so that they all have access to it and everyone knows what everyone's supposed to do. But there's no linear process here. It can all happen whenever it needs to happen. So then, using this example of the personal health network, why should startups work with researchers? So we built this on a platform from a startup called Teatros in San Francisco. They were actually incubated at UCSF. They had a platform and we were introduced to them. But the platform was being used to sort of coordinate studies that had multiple sites. So they would send out the consent forms to patients who were enrolling in it, and they would ship study documents to the study coordinators all the different sites. And we said, we are not really interested in a study coordination system, but we like the fact that you're using the social networking paradigm to organize a process across lots of people, we think it would be great if we could use this to create a care coordination system. And being a startup, they said, that sounds really interesting, and it seems to open up a whole new market, because they were marketing to researchers to manage studies. That's not a huge market, honestly, because we don't pay a lot of money for software to manage studies. But if you can do care coordination, now you can go to hospital systems, you can go to insurance companies, you can go to government programs and say, we have a platform that you can use to coordinate care. So they said, that seems like a market opportunity. So they were willing to work with us on it. So how did we work together? First, the question was, what solution should we create? Well, we had just come off of doing a year and a half of work to come up with the problem we think we're having is care coordination. And the framework that we think has to be built into any solution is this notion of community-wide care coordination. Meaning everybody who's involved in the community around this individual needs to be part of the workflow. So we had created this nice little framework that includes the person, the family, caregivers, the community, and the healthcare team. And this is what academics do. We published it. Yay! Okay, so we had the framework. So we said, what solution should we create? Something around the framework. And then the second question is, so how do you build that? Like, what is it that you actually build around this sort of theoretical framework? And so the first meeting after Teatros and we all decided we're going to partner on this, like, okay, what do you want us to build? And we said, hold on. There are two other frameworks in sort of care coordination. And there are 3 papers that have said, if you're going to do care coordination, you have to have these requirements in your system. And so we had done the lit review, and we said, okay, let's apply that to the cancer case that we're working on, and we came up with the user requirements. And this nice little chart, and we said, okay, Teatros, please do this for us. And then we wrote a paper. And you can actually see Teatros. Those 3 people from Teatros are co-authors on the paper. So those were the user requirements. So now they know what to, they know what to build. Okay. So how should we build it? So we come with expertise in participatory methods and user-centered design, and we know how to test solutions in the lab. So we brought those methods. We said, okay, if you build it, we're going to do all this stuff through the iterations of you building it, and that's how you're going to know you built the right thing. And then we wrote a paper about it. Okay. And then, how do we know if it was useful? Like, how do we know that we actually did anything? And this is what we're in the middle of this now. So we did a beta test with just 2 patients. We are just finishing a small randomized controlled trial with 60 patients. So we have 60 patients who half of them have a care coordinator, and half of them have the care coordinator with the personal health. So we'll be able to see that they have different outcomes. So we're in the small randomized trial now. We're just about finished with that. We've done in-depth user evaluation. So we had 30 patients, 30 caregivers, 50 nurses. So we have 3 different grants that allow us to do in-depth user evaluation. So we've done interviews and observations and surveys and all kinds of stuff. And all of that will wrap up in September. And hopefully we'll get positive results, and then we will go to a very large randomized clinical trial with hundreds of patients. So that's how we know if it's useful, right? Just because we had a few patients in our small trial, and they said, yeah, we like it, or yeah, we want to do something a little bit different, doesn't mean that you actually got outcomes, right? With 60 patients, you can't actually calculate whether the effect you had in the small trial is going to hold when you try to generalize it to a large population. You need a large trial to do that. And that's what academics can do. So we're in the midst of this. And then we wrote another paper. Okay. So I think if you talk to Teatros, they would say that the value has been in having people who thought about these issues really deeply and done lots of research on what should be done and how to do it, that they could partner with to actually design and develop this product with the best chance of making a difference. And so, hopefully, the impact is that we have a solution for patient engagement, and that that solution actually improves health. And I'll end with this. So, most of our interactions as patients with the healthcare system are really under the tip of this. In fact, most of what we do around our health, we do on our own, like in our daily lives. So self-care is, and always has been, our predominant form of healthcare. This is the reason why patient engagement is so critical. It's the means to an end. It's the means to becoming healthy. That autonomy is not just the goal, but in fact is necessary. And I will take questions. I do a good job of convincing the entrepreneurs that they need to work with researchers. All the things we can do for you. Yes.
Maybe I'm not your target market because I was one of the bubbles up there with the connected care coordination, which doesn't always occur, sadly.
Yes.
I'm on the hospice end of the spectrum. I wasn't totally clear. Does your app pull from electronic medical records like Epic and McKesson's?
It doesn't pull
product?
from them now. It will in the next phase, and we just got another grant that's starting July 1st, where we're actually speccing out how all the data that the patients generate from the apps can get into the medical record.
Yeah.
Right? Our health system, most health systems don't like to send medical record data out to an app.
Of course.
But if we can generate it in a standard format and get it into the EHR, they're more willing to consider that. So that's what we'll be doing this next year.
Yeah, that's where I would imagine you get the most interest from providers is when our data is in that app. Because when you were predicting the frequency on the meds,
Yeah.
I'm thinking, I wonder how closely that may not match with the physician's order.
Exactly.
So that's a problem from a provider standpoint.
That's exactly right. So medication reconciliation. So I showed you from the user, from the patient's perspective, what that looks like. The challenge from the healthcare system is that you've prescribed all these medications. You have no idea whether the patient filled them. And even if they filled them, you don't know if they're taking them, right? And so there's this mismatch between what you think they're taking and what they're actually taking. So one of the features in that app is actually a summary of everything that the patient thinks they're taking that we can match to what is in the EHR.
That's perfect. And if it matched the actual order that you pulled from the EMR,
yeah,
you know,
exactly.
you got a great opportunity.
Yeah. So that's why we actually start with meds, because we have about 15 advisors that are split between clinicians and patients. And it was the first thing that came out that is a big problem for both patients and providers. But they have the challenge is different from those perspectives. And they said you can bring those two together and solve it for both of us. That's win-win. That's actually why we started there.
How long until you think you actually have something that people could use? You're in research.
It's already in use.
It's in use?
Yeah, so this, the Personal Health Network screenshots, this is actually version 2. So we started with version 1 over a year ago. And our first evaluations, we fed that back to Tietros and they went into a version 2. Version 2 has already been marketed, so it actually did open up a whole new market.
How
So they
many?
now have a number of other companies using it.
How many patients are participating
In total or in ours?
in your, well, in total, I guess, using the idea that
Yeah, I don't know.
Okay, how about in yours?
I should have brought Tietros with me. Yeah, that I don't know. I just know how many we have.
How many do you have?
We just have 60. We're still in that
60.
small trial
Uh-huh.
of 60. Yeah.
How long do you have to wait to see the outcomes?
So we already have generated outcomes from the Personal Health Network trial. So people were in our coordination trial for 6 months. The project has gone 2 years because we've had sort of rolling enrollment, but we have to keep everyone in for 6 months. So we will have all data collected by September, but we've already done the initial analysis of the people who completed after we just did that last week, because we present a poster next week. So we're starting to see the results already.
So what is like the perspective into going to other problems besides cancer, right?
Yeah.
There are some other complex things. So is there a way that you can make a general app, or do you really have to go and tackle each?
No, and so the technology itself is a platform, right? It's not a hard-coded app, so it's a platform. So let me introduce part of the team. Twee and Ron are our junior research specialists on this team. They go in and configure whatever they want. So they can configure it for cancer, they can configure it for heart disease, they can configure it for whatever. So it's a platform. And then let me introduce Victoria, who's our project manager. And so we're very interested in using it for other chronic and prolonged conditions. As a heart failure is of interest to us, diabetes is of interest to us, COPD, asthma, all those conditions. So that's the importance of having a startup company that has a platform that allows you to be flexible about how you use it.
So you were saying how you guys use the barcode when people are initially putting these, they have all the medication.
Yeah.
Is there any talk, much like in the hospitals where you barcode it when you actually take it, so then you can track to see if people are taking it and give them reminders if they weren't?
Yeah, so they have the RFID chips now they put in the pill itself, so then you swallow it. I don't know that I would take that. But, so we haven't gotten to that yet. So here's, this is one of the reasons why I think working with researchers is really important. So we've studied a lot of behavior change theory. And the issue for most people in taking medications is not just remembering to take them, right? It's not just the reminder. It in fact is all the stuff around the medication taking process. It is knowing if that medication is really important. Does it make you feel better or not make you feel better? Because if you have side effects that you don't like, you're probably not going to take it whether you get reminded or not. And the perspective of the patient is, I don't want a provider or a care coordinator or nurse somewhere else policing it, right? So I don't want to have to enter every time I do it just to have someone call me. It's like, why didn't you take your medication? Right, so the policing mechanism actually demotivates patients. So you don't want to police them. So you have to give them a way of organizing it so they have the best chance of adhering to their schedule, and giving them a way to track for themselves whether they're taking it or not, and how they feel about taking it or not. So we do have this tracking component here that's not as well designed yet, that allows you to quickly say, I took it, I didn't take it. If you didn't take it, why? Because the why is what's important, not you just not take it, didn't take it. So we think about like behavior change theory and what does it do if you try and do a reminder? What does it do to a patient if you try and police them? What does it do? Like, what are the ways to motivate them that are not going to have those unintended consequences?
What kind of patients were you looking for in testing this technology?
So for the Personal Health Network, it was patients with cancer who were just diagnosed. So they were starting the first round of chemotherapy. So it was, but other than that, we didn't have any age, well, all adults. So we didn't do pediatrics, but all adults. Any age, any site, any stage. So this is what we called a feasibility trial. So we did a random assignment. We're just trying to see if it's feasible. Does it work for the patients? Will they accept the technology? Does it kind of work for the care coordinators? Like, does the information flow in the way it's supposed to? So it's a feasibility trial. The next stage, where we go to a large randomized trial that will probably have 250, 300, 400 patients in it, then you have to get much more strict about the criteria and who you're testing. Those have to be much more controlled.
With the multiple mobile apps, do you see them combining into a single kind of centralized point of care?
Yeah, the centralized system for the health system has to be EHR. Right? So all this information that's relevant to clinical decision making has to get into the EHR. So then we're talking about interfaces or our real integration. So the OnPoint, which is the medication and symptom app, is actually on iOS, and we have a partnership with Epic to use Apple Research Kit, that mechanism to get the data from our app into the EHR. With the Personal Health Network, it's actually on Android. I don't like Apple. So we started with that first and didn't do it on iOS. We will have a bigger issue with that, but we have a clinical informatics person who is a national expert in how to standardize data. And so she's speccing out how we will get it into the EHR, even if we're not using research. So for the clinical side, it has to be the EHR. On the patient side, if they have a PHR, a personal health record, that's the perfect place that they control to have all this information. Most people don't. Right, so then the question is, do you try and get all of these applications to be on one single platform, and then you have this massive enterprise software that can't run on your cell phone, right? So it's a challenge on the patient side, because we don't have.
Yeah, I'm just wondering if you're going to have the same kind of fragmentation that you see in the EHR world.
Yeah.
It's different.
You definitely could. Well, that's what we have now,
Yeah.
definitely. So at least right now, we have 2 platforms we're using. But like I said, if Epic really goes down this path of using ResearchKit and HealthKit to get data into Epic, and then they truly allow you to have the patient portal on Epic be open and flexible so that you can allow patients to get any of their information through the portal. There's 2 ifs. Then you can use the EHR to do it for patients as well. Those are 2 big ifs.
I was wondering who pays for that integration.
Research grants.
Very good, very good.
Right now it's research grant. Until Epic sees a business case for doing it.
Exactly.
And because of Precision Medicine Initiative and some other sort of national payers that are starting to demand it, there may be a business case.
Two questions. One of them is, it seems that for the second example that you gave, you are working with a startup company
Yes.
already. For the first example, it seems like you have something, a prototype, but you
Yes.
don't have a company that you're working with.
We don't have a company. We'd like to license it. Who wants to buy it? Someone want to buy it? So on that one, we actually built it from scratch because we were just prototyping, right? But the idea is that if it works well, if it is helpful to people, and we get through and we are actually showing impact, then we may try to license it out or make it sort of public domain, open source, let people use it. So any of those are options.
So the second question, how did you come about for the partnership with the startup?
Todd Stoltz
Okay.
do you know Todd?
Yes, I do.
Okay, there you go. So I don't know, he talked to somebody and said, oh, have you seen this company called Teatros? They're a startup. And he met with them and thought it was interesting, and then he called me and said, do you want to look at this? That's how it happened.
A question about like the model that Kaiser has, where they're both the payer and the provider. It seems like an organization like that might have an easier time maybe adopting this kind of technology because well, you don't have as many people, as many different.
Maybe. I mean, I think adoption is different than business model. Right? They have a business model that's more integrated, so that you have more alignment between the payer and the hospital and the physicians. Right? So they can more easily say, okay, we're going to do something. We all agree. But adoption of a new model of thinking about care is not, I don't think, any easier there. And Kaiser's real push is efficiency, reducing costs, because they used to be the low-cost provider. They're not anymore. And they're trying very hard to become a low-cost provider again. And so we don't know yet if these kinds of engagement strategies actually reduce costs. So they may not be willing to just get behind it until they know. Right? It may improve care, but it might not improve costs. In fact, there's research that for middle class and wealthier white people in the United States, when they get more engaged, they use more healthcare without necessarily getting better outcomes. Okay. So that's a lot of Kaiser's, user base. So maybe they don't want quite that much engagement yet.
I'm very interested in symptom logs. I think there's a lot of issues that come up when you use symptom logs.
Yeah.
Some of it is, how recent was, are you saying, did you have a symptom yesterday,
Yes.
in the last hour, last week, related to this medication? You get really different answers depending on how much time has elapsed.
Yes.
So it's really important to ask people right when the symptom happens.
Yeah.
How are you feeling? What's the intensity of the symptom?
Yeah.
So that you can link it to the medications and things. And another issue that comes up is different personality types. You have some people who are very withholding from their doctors. Well, how do you feel? Are you getting any side effects? Oh, I'm okay.
Yeah.
And then the
They
other
don't
people
want to bother the doctor.
that don't want to bother the doctor, and they get a different, and people who are the opposite say, oh, this is bothering me, when maybe it's just bothering them a little. They'll get more medication switching.
Yes.
Much more. So those are some issues that might be really important into building into this to gather extra data.
Absolutely.
For
So
those
symptom
issues.
logging, right, where you are sort of constantly logging symptoms to try and capture it in real time is very difficult.
Yeah.
People just can't keep that up.
Yeah.
Right? That's where you actually need wearables and sensors.
Yeah.
Right? And they're not great for most symptoms. So what we're doing in this application is actually proactive screening of symptoms, not constant logging, but proactive screening. And these are based on evidence-based protocols about the most common symptoms and the best way to ask about those symptoms. So that you can target just right now, so on some periodic basis, each week or every 2 weeks, what is the most important symptom to you right now that I can address? Right? You just can't do that continuously if you're using that sort of proactive symptom screening type of question. So, but what you're talking about, I think we really have to get more to sensors.
So another question is, how much is this? Can people buy this
Teatros?
mobile app?
Yeah, Teatros you can buy right now. I mean, we have a special price.
Yeah.
Because they're a partner of ours. I'm not going to tell you what our price is. But they do have contracts with a number of organizations
And
that they're selling this right now.
how much is it for, small numbers of?
I don't know. I only know what my price is. If you touch with them, though, you can ask
Is
them.
it affordable?
It's affordable for me. My project.
Well, I'm sure you are. Security concerns about the information getting in the wrong hands.
Yeah. Yes.
Okay.
Security concerns.
You have that,
So,
I know.
yes. Well, so the Personal Health Network, so Teatros went through an audit. They signed a HIPAA Business Associate Agreement, so they've been through an audit. So we know that they are HIPAA compliant. For the health system, that's the bar, that you have to be HIPAA compliant.
Right.
And so, yes, it's encrypted on the device. It's encrypted in the database. Is it truly encrypted over the air? We don't have true encryption over the air, so for most things, like if you're going over, a commercial internet, I don't think that they can guarantee that part of it. But so yes, you have to be very careful about that. So we have, two-factor authentication for logging in, so that those kinds of safeguards in place as well. So we're doing as much as we can. So for patient-generated data, it is actually not a HIPAA concern until we get it. When they do it, we're not responsible for anything. So on their own app, it doesn't matter. Right, but because we're looking at it, and we will take it into our health system, even if it's just on a research basis, we have to be concerned about it. Yeah, so those are definitely concerns.
You've talked about UC Davis specifically, and they're on an Epic system. And I know Epic specifically is very specialized for every medical center that they're on. And there's also other major electronic medical records. You've thought a lot about how to incorporate multiple electronic medical records, and to what degree does this standardization of the informatics work?
Yeah, so we know a lot about health information exchange. How standard are we in the medical record systems?
Well, it depends. I mean, there is a meaningful use requirement that everybody can export a CCDA format, which is an HL7 format that says, certain names of fields, so that in theory everything could be connected, but in reality, you probably can't easily connect UC Davis and UCSF because they probably have different data dictionaries for how they manage their data in the different parts of that CCDA. So.
So it's
somebody
not.
asked me a week or so ago a similar question, and the answer is it depends. It's kind of like talking to a lawyer. It depends on who, which two organizations and how closely they've tried to make that happen. Somebody says, well, we should make another standard so that everybody's doing the same thing. And then you've probably seen the cartoon where they have 13 standards, so we're going to make a unified standard. In the end, they have 14 standards. We don't need more standards. What we need are what's called implementation guides. So you have existing sets of standards, and everybody follows the same rules about how the standards are implemented. We're not quite there yet.
So the intent of this project that we just got funded that's starting in July is to actually look at how we could take the data in the app and use HL7 standards to get it into any EHR. But we won't actually do that in this 1 year that we have the grant, but we will at least spec it out.
Wow.
Great. Thank you so much.
Thank you.